to tonight's webinar, where we will be discussing the management of cow's milk protein allergy during the COVID-19 pandemic. My God, we're still talking about this pandemic, almost 12 months into it, but hopefully we're not too far. Hopefully we can all see that light at the end of the tunnel. So for those of you that don't know me, my name is Ibrahim and I'm a general practice pharmacist based in Bury, Greater Manchester, for those of you who want to know exactly where. And I'd like to start by thanking all of you for taking the time to join us during what it has been a particularly challenging time. And I know for definitely in primary cases, between juggling the day job as well as dealing with pressures caused by the pandemic, I really do hope you're all well and taking care of yourselves. And in this current virtual world we live in, I'm really grateful to Nestle Health Sciences for supporting us this evening to bring us all together virtually, if not in person, to hopefully share some good practice and discuss guidance. I really do miss the old face-to-face meetings, but hopefully that's not too far. But I suspect for a while this is going to be the norm. So in recent years, the complexity and range of infant formulas available has resulted in increased costs, inappropriate prescribing, and an increased burden on everyone, as far as I'm concerned, community paediatric dietetic service for definite, as well as some primary care. And I think we're really fortunate this evening to have someone who has played a huge role in developing the local CMA guidelines in Leeds, and hopefully we'll be able to support us clinicians no matter where we are in the country with maybe giving us a few hints and tips with regards to correct diagnosis and an ongoing management of CMPA. So Dr. Donald Hodge is a consultant in paediatric allergy and general paediatrics at Leeds Children's Hospital. And I'd really urge you all to take advantage of his expertise, and I hope we can make this evening as interactive as possible. So from my perspective, I do a lot of meetings, but it's very, very rare we get something that's such a niche subject. So I'm particularly excited about this evening's webinar. And what I would say is if you can just keep your questions coming throughout the evening on the chat function, I'll make sure that I ask on your behalf when appropriate, probably towards the end. Just a bit of housekeeping. So once again, this webinar is being recorded this evening, and I'd also ask you all to keep your webcams and microphones turned off to ensure that there is no impact on the quality or the bandwidth. Once again, there will be plenty of opportunity for questions. So if you can maybe put them on the chat function throughout, and I will submit them and ask on your behalf towards the end. I don't think we can actually take any verbal questions this evening, but once again, if you make sure you put them on the chat function, I'll be more than happy to put them over to Donald. So without further ado, Donald, over to you. Thank you very much.
Perfect. Good evening, everybody. Thanks for the opportunity to come and talk about cow's milk protein allergy, which I know is a condition that a lot of even consultant paediatricians, junior doctors find difficult to manage, and that really relates to the constellation of different symptoms that babies will present with. So over the next sort of 40 minutes, I'm going to give you a little bit of a framework in terms of sort of, some good pointers to try and make the diagnosis, a little bit about how you can differentiate between cow's milk protein intolerance and gastroesophageal reflux, and a little bit about sort of what milks are available and what the difference between the milks are, and then a little bit on how practice has changed. And ironically, cow's milk protein allergy is a condition that actually lends itself very well to remote diagnosis, because it actually comes down to history taking and collecting a constellation of symptoms and then making sort of changes in milk. So actually there isn't really a need for a face-to-face consultation to make this diagnosis. In terms of making the diagnosis, we know that cow's milk protein intolerance is very common. And in fact, allergy is now the most common condition that you will see in general practice, be it sort of atopy, be it eczema, be it asthma. It's much more common in formula-fed babies. And interestingly, around 50% of the diagnosis is still made in general practice, but we still know that it takes quite a lot of time and quite a lot of visits in terms of healthcare people to make the diagnosis. In terms of the sort of typical sort of journey that we see is that, we certainly see the onset of symptoms often within sort of a month or 6 weeks of birth, when the children can present with sort of crying, reflux, a bit rashy. There's then often a worsening of sort of crying and spreading of rash. There's then a sort of a series of things that that the families then do. They sort of change detergent. They then go through a multitude of different formulas off the shelf that they can buy in the supermarkets. They get rid of the dog. They change nappies. And then there's sort of, you know, some other treatments that are often tried, and I've seen antihistamines prescribed. I've seen sort of anti-reflux treatments prescribed. And then often there's a crunch event that tends to happen, and you know, often we don't like to see it, but often you get sort of situations where families often take matters into their own hands, often driven by social media. But still, the average sort of age of diagnosis is still around about sort of 5.5 months, which is very late in terms of, you know, the history that's gone on ahead of them. What is cow's milk protein intolerance? Well, we know that it's an abnormal response to a protein in cow's milk, which some kids will recognize as being potentially problematic. Thankfully, the majority of don't, but if it does generate problems, then it generates antibodies against milk. And it's fair to say that most babies with cow's milk protein allergy will present in the first 6 months of life, and it's very, very rare to get it after 12 months of age. If children start to get problems at that sort of age, it's usually something else. Cow's milk is complicated, and we know that there are up to 25 different proteins present in cow's milk, which can induce antibody production in humans. If you look at the proteins that are present in cow's milk, the whey makes up 80% of the protein, and casein's 80% and whey is 20%. If we look at what's in human breast milk, you can see automatically we've got a bit of a problem, because the whey and casein ratio is the wrong way round. But not only that, is that the casein content actually varies during lactation. So it's very dynamic breast milk and changes depending on how old the baby is. This red slide at the bottom is by far the most important, that, you know, beta-lactoglobulin is present in breast milk. So cow's milk, beta-lactoglobulin is present in breast milk. So essentially, if you've got a breastfeeding mum who has got cow's milk in her own diet, the majority will express cow's milk in their breast milk and will therefore be transferred to the baby if the mother is breastfeeding. I'm often asked about what is transferred through breast milk that may cause problems in babies, and these are the big sort of 4 proteins that we are very comfortable that are transferred. So cow's milk clearly is. Soy is also transferred in breast milk, as is egg, as is peanut. So those are the big 4 proteins that are definitely transferred. I hear lots of stories from other mothers worried about other minor proteins that may be transferred, but to be honest, it's often very difficult, and there's no way of particularly proving it, but often it's very easy to say, well, just avoid asparagus if you're convinced it upsets your baby. In terms of the sort of symptoms of cow's milk protein intolerance, there are 2 very different cohorts that we recognize. There's the IG mediated one, and this is true of any sort of food allergy, with rapid onset of symptoms within an hour after ingestion. And about 30% of babies who are allergic to milk are in this sort of category. In my experience, it tends to be, you know, breastfed babies that are given their first taste of yogurt at 6 months of age, or the other sort of classic presentation is usually after the babies have had some sort of creamy porridge or one of these commercial sort of products that mothers can buy for weaning. You know, they add a bit of breast milk or they add water, but actually unbeknown to the family, it's laced with skim milk powder. And for a breastfed baby, this can often be the very first hit of a big dose of cow's milk protein. Its immune reaction is driven by mast cells, and the testing that we can do is usually positive. And you can develop anaphylaxis with this type of allergy. The more common type of allergy, and the one that we see more common certainly in primary care, is the sort of non-IG mediated, or the sort of the intolerant baby. And symptoms are delayed and can be up to an hour or up to days after exposure. And about 70% of babies will have this type of reaction. It's not really an immune reaction driven by eosinophils and T cells. And symptoms are often sort of dose related. And it's more difficult to diagnose because there isn't any testing that you can do. And the history is really the clue to making the diagnosis. And then we avoid the milk protein in either the breast or the bottle-fed baby, and we're looking for a symptomatic improvement. The majority of babies who have cow's milk protein allergy will have symptoms affecting more than one organ. So we hear about skin symptoms, we hear about respiratory symptoms, we hear about digestive symptoms, and then a sort of general sort of symptoms. Skin symptoms are common, and clearly in the Ig-mediated children, we hear about sort of itch, we hear about erythema, and that even often happens during a bottle feed. But clearly we hear about hives. They're not usually too difficult to diagnose, and we hear about sort of acute angioedema as part of an acute allergic reaction. The non-Ig or the intolerant babies get sort of itch, they get erythema, and they get eczema. So eczema rather than sort of urticaria. Nasal symptoms and respiratory symptoms are, again, fairly common, up to about a third of babies. And in the intolerant babies, we often hear about sort of nasal congestion or sort of, nasal sort of congestion and sort of sounding snuffly all the time. In the Ig mediated as part of an allergic reaction, we certainly hear about sort of almost like acute hay fever type symptoms, but we can hear about chest tightness and wheeze and anaphylaxis, and clearly that is sort of the end of the spectrum. We don't hear much about anaphylaxis, but I probably see a couple of babies aged less than 6 months who have anaphylaxis to milk every year. And it's fair to say that you don't usually get respiratory symptoms on their own. They usually happen in conjunction with another sort of manifestation. Digestive symptoms are common, and certainly in the acute reactors, we hear about vomiting, we hear about diarrhea. The Ig-mediated delayed children, get a multitude of different symptoms, including reflux. They get sort of colic, they can get vomiting, they can get loose stools, bellyache, food refusal, and they can also get constipation. So a lot of people don't associate cow's milk protein intolerance with constipation, but certainly a lot of babies do get that rather than diarrhea. But then we hear about sort of blood and mucus in the stool, and sort of I quite often hear about perianal redness that isn't really typical of nappy rash, but sort of the families will describe as sort of a bright red ring around the sort of anus. And then the sort of general symptoms, which again sort of never happen on their own, because these are just sort of general baby symptoms, but we like to have other symptoms plus this sort of history of fidgeting, irritability, sort of back arching, poor sleep. And certainly in the severe babies, we do hear about sort of faltering growth and failure to thrive. Tongue tie is an interesting condition that, when I was a junior doctor and even sort of as a registrar, we were taught that tongue tie, had only two pathological outcomes. One, that you wouldn't be able to French kiss your future wife properly or boyfriend properly, and then you wouldn't be able to stick your tongue out at the teacher properly when you were of school age. And we now know that, tongue tie has become the new sort of sexy diagnosis, and there are hundreds of ENT clinics or private tongue clinics up and down the country where babies are queuing up and having their tongue butchered. The incidence is about sort of 5%. And the only reason I put this slide is the number of children I do see who have already been to an ENT surgeon or paid privately to have their baby's tongue snipped, who then present because it's made no difference. It's almost about sort of 50–60% of children it's made no difference. And if you look at the symptoms of tongue tie, unsettled behavior during feeds, difficulty staying attached, frequent or long feeds, excessive weight loss, clicky noises, colic, wind, reflux. So don't get me wrong, some babies do need their tongue tie operated on, but it's certainly not the majority of babies currently queuing at the moment. And the reason I put this slide is that if you are referring a baby, to an ENT surgeon, for tongue tie, it's just to have a think, could this baby have cow's milk protein intolerance? Because certainly it's more likely to be that than to be a problem with the tongue. Lactose intolerance is often confused, and clearly lactose is the primary sugar that's present in breast milk, and that is its only association with cow's milk protein allergy. Lactose is normally in breast milk and also in cow's milk. It's a big sugar, and the normal pathway is that it goes into the small intestine, where it is digested by the enzyme lactase in the small intestine. It's then cleaved into smaller sugars, which then continue their journey through the gut, and it doesn't cause any problems. So primary or congenital lactose intolerance is phenomenally rare, quite common, even rare in Finland and Russia. I've never seen a case myself in the UK. Secondary lactose intolerance you will see a lot of in primary care, and this is the child who previously was tolerant of milk, who then goes to nursery, who gets a severe gastroenteritis, norovirus or enterovirus of some sort, and then for a period of time appears intolerant of milk. There's usually quite a long history of sort of the gastroenteritis before they start getting symptoms, and the babies are transiently lactose intolerant because the brush border in the small intestine has been damaged by the gastroenteritis, and the children get diarrhea, they get wind, they get abdominal pain, and it's all because they've got a big sugar present in the gut, where in the colon where it shouldn't be. The colon can't handle it. It sucks water in, so babies get diarrhea, and it ferments, so they get this sort of frothy, explosive diarrhea. And the treatment is to use a lactose-free diet for a period of time, and then to reintroduce normal formula after a period of time. And the key in diagnosis is that up until that episode of diarrhea, this child was fully tolerant of dairy. So sudden loss of tolerance to milk is usually lactose intolerance and not cow's milk protein intolerance. Breastfeeding should continue because there's nothing the mother can do to alter the lactose content of her breast milk. Now, there isn't usually enough lactose in breast milk to cause too much of a problem. And again, breastfeeding must continue. I'm often asked, and families often struggle to differentiate between, you know, does this child have a problem with the milk, or does the child just have a gastroesophageal reflux? And the Coma Score is something that we use every day, and I use it all the time in terms of trying to really work out, you know, is it the milk or is it just boring sort of gastroesophageal reflux, which is physiological and common. And it's an awareness tool with a sort of a scoring system. So there's a score for crying, and the mothers are asked to estimate how many hours a day the baby cries, and of course recognizing that babies are allowed to cry for 2 hours a day. That is normal. There's then a score for regurgitation, and that will quantify frequency of vomiting, but will also look at sort of volume as well. A score out of 6. There's then a score for what the stools look like, and that relates to a big score for watery diarrhea, but also, as I said before, some babies will get constipated, so there's a big score for constipation. There's then a score for sort of skin symptoms and a score for sort of respiratory symptoms. And this really, as I previously presented, you know, captures a scoring system from multiple different organs. Then you top the score up, it's out of 33. If you've got a score of more than 12, then greater than sort of 80% positivity value, there is a problem with the milk. If your score is less than 12, then this baby will almost certainly just have gastroesophageal reflux that needs treating appropriately. So this really will help, you know, unpick, you know, is it just reflux or is there a problem with the milk? And it's quite an easy sort of scoring system. And we like sort of scoring systems now. And there are lots of sort of apps available, not only for constipation that we see families using, but this Smiles Back app, again, is a very good way of families being able to sort of capture, you know, a previous week or a previous 2 weeks worth of clinical data. And the families are asked to sort of chart, you know, the frequency of feeding, you know, what the nappies are like, you know, how much regurgitation, you know, what the baby's like, what the skin's like, and it will sort of then generate a weekly report. And, you know, we find this quite useful in as much as the families can't remember how many times the baby vomited, you know, last Thursday, but if they download an app, they can clearly chart it. And again, it's about sort of building up evidence. And I quite often get families to, you know, to download these apps so that they can sort of present them with, you know, detailed sort of chronology. So how do we make the diagnosis? You know, we know we've got a constellation of symptoms to look for, and that really relates to sort of taking an allergy focused history. There's then a sort of series of doing sort of elimination diets. There is a role for some testing if we think the allergy is IgE driven, and then we do sort of food challenges and reintroduce foods later on. This is lifted from, you know, sort of nice guidance. This is how you take a, you know, allergy focused history, but we do look at sort of family history. We look at age at onset, you know, what are the symptoms, you know, what is the time interval between exposure and symptoms, you know, severity, are they reproducible? You know, there's then a sort of a bit of a feeding history in terms of, you know, what milks the families have tried, or whether mum's already made some changes to her own diet, and a bit of sort of weaning history. And then sort of, you know, a bit of a history about sort of, you know, what treatments have been tried. And certainly, you know, I do this every day, you know, going through, well, what bottles did you, when did symptoms start? You know, were they skin symptoms, gut symptoms? You know, then what you try, and you often build up a very detailed chronology, you know, of actually, you know, well, I tried a few comfort milks, I tried a few, you know, different off the shelf milks, and then the eczema got bad, and then the vomiting got bad. So, you know, it's usually quite a sort of an easy history to sort of, and chronology to put together. So in terms of the diagnosis, for the IG mediated, it's driven by mast cells. We can do skin testing, you can do blood testing, and the treatment is to avoid. And that's usually very straightforward. The non-IgE, the history is made purely on history. So it's about sort of constitution of those sort of symptoms affecting the respiratory symptom, the skin, the gut and general symptoms, looking to see whether the child has a constellation of these. As I say, there isn't any testing we can do, and the treatment is to take that food out of the diet and see if things improve. So this is the IMAP guidance that came in, a number of years ago to sort of try and really help manage cow's milk protein intolerance in primary care. And it's a couple of quite sort of busy slides, which I've sort of broken down into 2 easier slides to follow in terms of how the baby is being fed. So in terms of the breastfed baby, we want to eliminate all cow's milk and also soya from maternal diet. And the reason we avoid soya is we know that if cow's milk is causing a problem through breast milk, in about 80% of babies, soya is also a problem. So I always take soya and milk immediately out of mum's diet. There is absolutely no reason for that mum to stop breastfeeding. Absolutely no reason at all, and it breaks my heart every time I hear about a mum being recommended to switch to bottle feeds and stop breastfeeding. So there's no reason to stop breastfeeding. So it's elimination of dairy and soya from maternal diet, and it does take a bit of time, for mum's breast milk to be totally washed clear. We clearly need to make sure that we're looking after mum's diet, and I certainly tend to recommend the mums use plant-based milk as an alternative, so oat milk, almond milk, one of the nut milks, one of the rice milks. But really, mums all need to go onto a calcium and vitamin D supplement. Mum needs to have 1,000 milligrams of calcium per day, which she will struggle to drink. So what we generally would do is mum goes on to a pregnancy breastfeeding supplement, which usually have about 700 milligrams of calcium in them, and then the mum will make up the rest of it through a milk that she will drink. And it can take, as I say, 2 to 4 weeks for symptoms to improve, and that just represents how long it takes for mum's breast milk to clean, so to speak, in terms of getting cow's milk out. If that mum wants to top up or the baby needs a formula, then we would use an extensively hydrolyzed formula in that case. In terms of the formula-fed baby, again, it's about removing cow's milk protein and remembering that the formula milks clearly all have cow's milk as their initial source. So these babies all need to go on to an extensively hydrolyzed formula. And I'll talk a bit about the different milks in a few slides. But that really is the first line. There are very few babies that need to go on to the extent, the amino acid based, really expensive milks. And certainly in Leeds, we have a zero tolerance where, GPs and either A&E can't instigate amino acid based formulas, because nationally there is a huge problem. We know clinically about 10 to 15% of babies clinically need these expensive milks, but nationally about 30 to 40% of babies are still being prescribed them. So your first line is an extensively hydrolyzed milk. We then know that once these babies are changed in terms of mums avoiding milk and soya, and the babies are then put onto an extensively hydrolyzed, and the pathway is that these babies then need to be re-exposed. So breastfeeding mums should put milk back into their diet and breastfeed and see if symptoms recur. And the bottle-fed babies should be put back onto standard formula to see whether symptoms recur. And the reason that this step is very important is that we know that about 30% of babies, when re-exposed to the normal formula, are fully tolerant. And that saves you prescribing expensive milks, but also saves the families weaning these babies dairy-free. And this is a really important, quite often families resist this step, but it really is an important step to really nail the diagnosis. And clearly when symptoms recur, they go back to an extensively hydrolyzed, and then they are committed to being weaned dairy-free. In terms of milks, there's often a bit of misconception as to how milks are made. So down here on the left-hand corner, we've got standard formula, and it's made from cow's milk. And there are some pretty chunky, big cow's milk protein formula proteins in there. We've then got some formulas which the families can buy, and these are sold as comfort formulas where the milk companies have added some enzyme to the milk formula to break it up into smaller chunks so the baby doesn't recognize it as being from cow's milk. And we certainly don't use the partially hydrolyzed or comfort milks in clinical practice because there's not really much evidence that they make a difference really, but certainly families will trial these. And then we have the extensively hydrolyzed, which are more digested. So these are, again, sort of digested up into smaller chunks. Again, this really is the way of trying to confuse or make the baby not recognize that the milk they're drinking actually has cow's milk as a source. And then we've got the expensive amino acid based formulas, which aren't 100% digested, contrary to popular belief. They are 100% synthetic. So they're basically a bag of amino acids with a few other goodies thrown in. So they don't have cow's milk as their source. The microbiome is important, and we're starting to know a little bit more about it, even with COVID these days. And we know that, we as human beings have, 100 trillion microbes, on our body, the majority of which live in our gut. And there's a number of things that affect our intestine microbiome in infants in particular. And this relates to, the sort of gestational age of the baby, the mode of delivery. And we know that cesarean section, being sort of ripped through the anterior part of your mum's abdomen is not really the way Mother Nature intended you to come out. And if you come through the birth canal, the newborn baby will be exposed to a lot of maternal microbiome and will ingest and swallow it. Type of feed is important. That clearly formula fed babies are exposed to sort of sterile milk, whereas breastfed milk is full of bacteria. And the use of antibiotics is important. So it's a particularly bad start to life to be born premature by cesarean section and then spend your first week of life on the neonatal unit being pumped full of antibiotics through fear of having neonatal sepsis, is not really great for your microbiome. And certainly on the neonatal unit, many neonates will give probiotics to babies who are born in that situation. And particularly we know that sort of human breast milk, has a big chunky probiotic sort of microbiome. So the human milk oligosaccharide, is a big important part of breast milk. If we look at sort of, pre and probiotics, most of the probiotics we hear about and the ones that are used commercially are driven from sort of lactobacillus. We hear about prebiotics, and these are really sort of the fuel that probiotics eat off. So, it's a number of different sugars, including lactose. And then we hear about sort of symbiotics now where, it's a combination of pre and probiotics. And there's a big sort of race now amongst the milk companies, about adding probiotics, to their formula milks, because we know that probiotics are very important in terms of mimicking human breast milk, but also trying, to speed up the recovery of that baby getting over its cow's milk protein intolerance. So in terms of the extensively hydrolyzed formulas and where you work in the country, you will have local prescribing guidelines that will tell you which milk you should be prescribing. There's only 4 extensively hydrolyzed formulas on the market. There's Nutramigen, and the sort of the LGG stands for the probiotic they've added. At 6 months, you change to the Chamagen 2. It's driven from casein. There's Aptamil, Peptin 1, Peptin 2, a whey-based formula, has got lactose added to it. Tastes a bit sweeter because of the lactose. There's then SMA Althera, which is derived from whey, again contains lactose. And then a sort of Similac Alimentum, which has now changed its name to Alimentum, which is really sort of the new sort of milk on the market, and certainly the one that I personally have very little experience of, given that I've never really used it because it's never really been, on the leads formally, but I know it is used nationally. In terms of how they're sort of digested, extensively hydrolyzed milks are digested using enzymes, and the proteins used for those, the enzymes used in most and all of them, apart from the Althera and the alpha-amino, is derived from sort of porcine enzymes. The SMA Althera and the alpha-amino use a sort of a microbial and a plant-derived enzyme rather than sort of porcine enzymes, and therefore, they are suitable for halal diets, and these are the only 2 milks that are halal. In terms of the amino acid based milks, Neocate has been around for a while, Neocate LCP. The Neocate Cineo, the Cineo represents the fact that it's got synbiotics in it. There's Pure Amino, and there's SMA Alpha Amino. As I said, these are the expensive milks which really need to be reserved for the most sort of severe babies or those babies with growth faltering. Dietitians are important, and we are very lucky in our clinic that we really do rely on the dietitians to make sure that the babies are getting enough sort of calcium in particular, and also the dietitians worry about iodine, but also our dietitians tend to look at maternal diet as well and do advise the babies about sort of weaning advice about what things to avoid. Does it get better? Well, we know it does get better, and certainly the majority of sort of the non-IgE babies, the sort of milk intolerant babies, get better by 2 years of age. The Ig mediated, so the babies that do react and sort of get rash and hives and urticaria, sadly 20% of these babies will continue to have symptoms into adulthood and never resolve. We do know that milk reintroduction is very important. And milk needs to go back into children's diet at a period of time. We know that the cow's milk sort of intolerant babies, it can take up to 6 months after diagnosis. So certainly the babies that we see where the cow's milk protein intolerance is diagnosed early, some of these babies can start introduction of milk at around sort of 10 months of age. The babies that present late and the diagnosis isn't made until 6 months, often they need to wait till 6 months after the diagnosis has been made. In terms of testing for tolerance in the Ig mediated babies, we use sort of skin testing to try and guess when we think the milk allergies got better. We then bring the babies into hospital and we feed them milk or yogurt, and we look to see if the babies tolerate it. In the non-Ig milk, the sort of intolerant babies, the dietitians start these babies off on the milk ladder, and it looks a bit like this, the milk ladder, and we've got sort of fresh milk up at the top of the ladder, and down at the bottom we've got milk that's been sort of cooked and butchered within an inch of its life and sort of baked, sort of biscuits, malted milk biscuits and muffin. And where you work, the majority of children, certainly in Leeds, the majority of children with a non-Ig milk allergy are referred to community-based clinics, which essentially are usually driven by dietitians, who will then support the family through introduction of milk using the milk ladder. And the majority of children, it takes a few months, but they do migrate up the milk ladder with no problem. The only babies that we do tend to worry a little bit about are those babies who still have troublesome eczema at the point of commencing the milk ladder. And some of these babies may have switched and have developed an IgE-mediated milk allergy. So certainly in our hands, we do tend to skin test these babies if they've got eczema before starting a milk ladder to make sure that they're still in the intolerant spectrum rather than the allergic spectrum. Other milks are available. And certainly, our dietitians are very keen to try and move babies away from prescription milks, as soon as possible. And thank God for the vegans, which have made life, a lot easier in terms of the range and multitude of different milks that are available. And, milks these days appear to be like sort of gin. You seem to be able to make milk from anything these days. So soya milk, we use, quite a lot of soya. There is a bit of cross-reactivity, as I said, with the sort of non-Ig milk intolerance. And some babies who have an immediate reaction to cow's milk will react to soya. So we have some, sort of anxiety about it. We never ever use soya formula anymore, and certainly wouldn't give soya to a baby less than 6 months of age. And I can't personally recall the last time I saw a child on a soya-based formula. They've sort of disappeared now, because I think we know the majority of these children should be on an extensively hydrolyzed formula. So it's very rare to see soya formula used, but we do introduce soya into babies' diet in terms of sort of getting it in yogurt and getting those sort of things when it's tolerated. Rice milk is not particularly good value for babies. You can't give it to children under 4.5 years of age because it contains a very large amount of arsenic. It doesn't tell you that on the packet, but certainly we very rarely use it. Nutritionally, it is very poor. We do let mums drink it if they're breastfeeding because it's not transferred in breast milk, but nutritionally it's pretty poor. We use quite a lot of oat milk because the families seem to, it does taste okay. There's now oat yogurt. So we do tend to use quite a lot of oat milk in babies once they're tolerant of oat, and certainly the families can add oat milk, to cereal, and it can have a little bit in sort of food and cooked. And the oat yogurts, ironically, are worth a look at. They don't actually taste too bad. Hemp milk, again, is a bit like rice milk, nutritionally very poor. It doesn't really have a particular place in the market. And there's the sort of nutty milks, which we do let some families use. Families tend to use almond milk or coconut milk. I very rarely hear about hazelnut milk being used, or cashew milk. The almond milk tastes quite sweet. Nutritionally is not very good, and that is because if you get 100 mils of almond milk, it's got about 95 mils of water, pinch of salt, pinch of calcium, and 2 almonds. So actually, it's not nutritionally very good, but actually it's quite good, to have on your cereal. And again, there's an almond yogurt that's come out. Again, we use quite a lot of coconut-based yogurt as well, if children are avoiding sort of soya and also milk. Again, I said it's like, milks are like gin, and every day there seems to be a new milk comes out. Pea milk is interesting. Tastes of peas, ironically, and is slightly green in colour. Some kids like it. It's a bit of an acquired taste. It's a bit meaty to drink. It's got a bit of sort of volume to it, and it's a bit chewy. I heard of one mother a few weeks ago that was adding it to her coffee. I hate to think what that tastes like. There's flax milk, which again is like sort of the hemp milk and rice milk, not terribly good. And avocado milk, which they sell in Waitrose, phenomenally expensive. And if you look at what's in milks, you can see that, why we try and keep away from the nutty milks. But, nutritionally, the calories and the protein, cow's milk formula, clearly big sort of players, soya milk, then oat milk. And then the nutty milks don't really have very much in the way of calories. Pea milk has got a phenomenal amount of calcium in it, which our dietitians do sometimes like. But most of the sort of nutty milks and the oat milk are all calcium fortified. So, have 120 mils of calcium per 100 mils. A2 milk, again, is a milk that you can buy in the supermarket. And this is sort of, comes from an Australian herd of cattle that have been identified of only sort of making the A2 protein. And when you look at sort of how it's sort of marketed, the research was only about sort of abdominal discomfort, and it's said to be easier digested. But essentially, the scientific sort of data behind A2 milk, comes from a bunch of sort of nat mums, sort of mums, where 85% would recommend A2 milk to a friend. Essentially, this is expensive normal milk, and if you hear about a family who are convinced their child is okay with A2 milk, they can buy normal milk and save some money, because it contains the same amount of cow's milk protein as normal milk, and it's not suitable for cow's milk protein intolerance. Other milks are available, and we certainly hear about sort of goat's milk, about pig milk, goat's milk, camel's milk, buffalo milk, but essentially these are unmodified and are just as allergenic. So there's a significant amount of cross-reactivity between sort of goat's milk and cow's milk, about sort of 95% similar. So certainly children allergic to cow's milk, we wouldn't use goat's milk or cow milk or buffalo milk because they're just as antigenic. So then in terms of sort of, summary, we know that cow's milk allergy can be immediate, in terms of the IG mediated with sort of the rash and the swelling and the hives. And again, this is rare in sort of bottle-fed babies. The sort of key time it presents tends to be the sort of breastfeeding mum, in a desperate attempt to get their baby to take a bottle, about to go back to work, will give a bottle of formula, or more commonly in my practice, I tend to see it tends to be yogurt. But say the creamy porridge, the sort of some of these Aptamil or the sort of hypoganic creamy porridge, are laced with sort of skimmed milk. So that tends to be the sort of the common cause. And again, symptoms are immediate and sort of rash and swelling. The delayed or the non-IG are the one that you will see more common in general practice. This is the itchy, scratchy child with bellyache and colic, sort of squirming, early onset eczema, reflux, constipation. And again, you look for that sort of constellation of symptoms, in different sort of organ systems. Cow's milk protein, can drive gastroesophageal reflux. You can use the Coma score, to try and sort of help differentiate between, is it cow's milk protein intolerant or is it reflux? In where you work in the country, will help with sort of the sort of diagnostic pathway, but the majority of the non-IG babies should be referred, either to community-based clinics or dietitians, depending on what your pathway is. Any baby that has an IgE-mediated reaction to milk, needs to be sent through to your local allergy clinic. It's about taking an allergy-focused history. And then you sort of switching the milks. The sort of breastfed mum needs to avoid cow's milk and soya, and then sort of avoiding those foods. All of the bottle fed or mixed fed babies need to go onto an extensively hydrolyzed formula. And as I say, your local pathway will help you to decide which milk you should be trying. In terms of just a little bit of sort of practical advice, in terms of milk prescribing, we know that most formula-fed babies in the first few months of life require 12 tins of formula a month in terms of how much you should be prescribing. In terms of trying to get some of these babies to drink the extensively hydrolyzed formulas, we know that they don't taste particularly great. So certainly I always recommend when GPs are initiating prescriptions, and we're very happy for GPs to do this, is that initially you prescribe 1 or 2 tins. Please don't prescribe 12 tins of extensively hydrolyzed milk immediately, because sod's law is that baby will turn its nose up, won't drink the milk, and then you've got essentially £300 or £400 worth of milk sat at home, and mum clearly can't return it to the pharmacy because no one will take it back. So when I'm initiating treatment, I get the GPs to initially prescribe 2 tins for the family to try for a week, and clearly if the baby's going to take it, then that can then go on to repeat prescription. Sometimes getting some of these babies to drink these milks is difficult. And certainly sometimes what I do is mix some of the feeds. So if the baby's on, let's say, a standard sort of formula, and I'm switching the baby to Althera, for example, I would get the mum to make up 4 ounces of the normal formula the baby's on, make up 1 ounce of the Althera milk, and then mix the 2 liquids together, and then over the course of a week sort of just alter the ratio and alter the sort of the quantities, and sort of build it up. So the next day would be sort of maybe 75% normal formula, 25% extensively hydrolyzed, mix the liquids, and usually over the course of a week, to get the baby used to sort of the smell and the taste, we can sort of confuse the baby, and the baby will then adapt it. Similarly, I do a very similar thing if I've got a breastfed baby and then mum wants to introduce an extensively hydrolyzed formula. Initially I'll prescribe the milk and say to mum, just try the extensively hydrolyzed formula. If the baby refuses, then I'd get the mum to make up a 4 ounce bottle of the extensively hydrolyzed formula, and then add 1 ounce or 2 ounces of expressed breast milk to that milk. And again, that will just give the baby some sort of sense of familiarity with regards to taste and smell, and often over a period of time, it will transition and get used to the smell and taste of it. The biggest problem with breastfed babies is that they usually refuse to take a bottle, whether it's got express milk or sort of a prescription milk. So that's often 95% of the battle, is getting that baby to take a bottle. It always usually does get better. So the mild, moderate, non-IgE sort of intolerance is usually managed in the community, referring the IG mediated babies to your local allergy clinic for diagnosis and ongoing care. So Ibrahim, that's me finished, so I can certainly switch back to you.
So first thing, comment by Timothy Reed. I think it's an agreement to some. Well, he actually commented before your slides came up about the under 5s and avoiding rice milk. I think your slide said under 4.5 years old, but either way. Yeah. Great bit of feedback, Timothy. Thank you very much for that. We have a question regarding, I know that you were involved in setting up your guidelines in Leeds, and there's a question regarding the Leeds local CMPA guidelines, and first of all, what do they say, and how was that decision reached? So have you got?
Yeah, I mean, it was a constellation of different sort of things that were put together, and it was a team of sort of dietitians, pediatricians, and I was not peripherally involved, but I was involved in terms of it does talk about the IG mediated, and I think I think the milks are all, slightly different. They've all got slightly different properties. I'm not convinced there is the perfect milk out there yet, in terms of a sort of a multitude of different things. But I think it's sort of, where you work in the country there'll be sort of different pathways. And certainly I know I can see a question there about deciding between, a whey-based or a casein-based milk. And again, I think it depends really what your local guidance is. We have SMA Althera as our primary sort of milk of choice. But certainly if I had a baby that wasn't tolerating, a sort of a casein-based formula, then I would switch them to a whey-based, extensively hydrolyzed as the alternative. So the slide I showed, there's 2 casein-based and 2 whey-based milks. If you've got a baby that isn't tolerating one extensively hydrolyzed that's casein-based, then switching it to an alternative that is whey-based is clearly the right thing to do. That's the way I tend to do it. And I say there isn't a right or wrong. The big sort of battle going forward, there's always questions about palatability. There's always questions about, what else is in the milk. Clearly, we've got quite a lot of families locally that will want a halal-based milk, and we certainly get a lot of families that, are not very keen on, on having sort of pork-based enzymes in their milk. So certainly religious views do come into matter. The probiotics are interesting. And then palatability, and then we do know that a lot of it, speed of resolution of symptoms. So it's a constellation of different sort of symptoms that we tend to use, or different sort of things, that we use to make our decision. I steer away from the financial aspects and how much milk costs. I know that's important to the milk companies, but certainly, I'm less driven by sort of how much they cost, rather than sort of symptom resolution and how quickly the babies get better.
Sure. So we got a number of questions, but to be honest, I want to just stop on a point you made regarding the halal certification, because obviously, from my perspective, there is quite a large demographic of my population, so to speak, that would be interested in maybe vegetarian or halal options. And to be honest, we do actually have the Althera on our guidelines, and I know you mentioned it during your presentation. I do think that halal certification is important, and it was something I was actually not aware of, because I do know there's a slight difference in the way the hydrolysis method, basically, and that's what is affecting. And as far as I know, with Althera, it's purely plants-based.
It is, yeah.
Is that right?
It is, yeah. I mean, I think historically, I've certainly had families in the past who have refused, to have an extensively hydrolyzed formula, and we've ended up having to prescribe amino acid-based formulas, which are more sort of suitable, but clearly much more expensive. And so certainly having a halal option is important.
Yeah, absolutely. And to be fair, that, as you say, those amino acid formulas are considerably more expensive, and in some cases, you're the expert, as far as I know, that they're only effective in maybe a small proportion of infants. Is that right?
Yeah.
So I have a question from one of my team in Bury, Angela, and she's asking, what's your experience with the new milk Allergy? So I was quite, to be honest, I wasn't aware of the Pea Milk that you mentioned, so that was something new to me. I practically live on almond milk, but Allergy, did you mention that in your presentation? Because I missed that.
I did mention Allergy. So Allergy is a sort of an Abbott-based, amino acid-based one. I don't have a huge amount of experience with it, just because it's not on our formula and it hasn't really filtered through yet. I think it is out there. It's been in America for a while. It's a bit like sort of the Similac Alimentum. There's sort of 2 new milks on the market. I don't have any sort of particular personal experience of ever using it, but certainly it wouldn't stop me using it if I felt that that it was indicated in a baby that was struggling with any other sort of milk that I'm familiar with. But it is out there, and a lot of places are using it.
Brilliant. I know locally in Bury, obviously our medicine optimization team, and Angela in particular has been involved in quite a bit of work with the local dietetic service and the health visitors to develop our pathway. And I suspect pathways maybe change from area to area, but there's probably not much difference. And I found it pretty pretty helpful with regards to supporting us on that and helping us maybe guide with regards to ongoing management of CMPA. But specifically, Andrew's come up with another question with regards to, in Berry, we have to engage with our health visitors with the re-challenge to confirm diagnosis. It works really well, and they will onward refer to dietitians if needed for dairy-free weaning, and then milk ladder further down the line. This is done in group session. What I'm particularly interested in is, I mean, how have you seen that change during this pandemic? Because I know for a fact a lot of our services have been maybe a bit less accessible. And how's that with regards to yourself?
Yeah, no, I think there will almost certainly be a number of babies who have slipped through the net in the last year who haven't had that sort of that reconfirmation or that re-challenge, which is, it's interesting. I'm seeing a number of babies now who are sort of 10 or 11 months of age, and I do wonder why these babies are on prescription milks, because I think in a different day they might have had that sort of challenge. So yeah, I think there will have been a lot of overprescribing, quite, sort of understandable sort of overprescribing, and it's very similar. I mean, I'll admit myself, I was not guilty, but I can certainly recall a number of babies in the first wave where you've got a mother who's crying down the phone at you about the baby that doesn't sleep, who screams, 24 hours a day. And I've certainly changed milks, and I've also given babies omeprazole, just to try and stop these babies presenting at A&E, to try and, it's not uncommon if I get a severe baby, sometimes it really is, there's such a sort of a crossover between, the cow's milk protein driving the reflux that I quite often, switch milk, and also I may start a bit of a PPI just to try and break the cycle, recognizing that after sort of a month I'll be able to stop the lansoprazole or omeprazole. But certainly, I had a number of babies, mums who were clearly on their knees, didn't want to come to hospital, so certainly there will be some babies. And I think it's a useful exercise for any sort of practice managers out there. It's definitely worth getting your practice manager to sort of draw a list of all babies in your surgery that are still on prescribed milks above 2 years of age, and ask yourself the question, who's signing these prescriptions? Because we do try and get these babies on either to coconut milk or almond milk or oat milk. There's usually some milk that the families can buy, so certainly, we move people on and stop prescriptions. And once the dietitians are happy, there's an alternative. So these prescription milks, need to have a bit of an exit strategy.
And I'd say that's definitely a role for, for practice pharmacists and medicines optimization technicians and whatnot, because that's something that we do see quite a bit. And it's funny, it ties into a question from David Ilston, based in Newcastle upon Tyne. Wow. As I say, we were national today. So if a child with non-IgE is struggling to introduce the milk ladder after 2 years, but rest of the diet is fine, and parents want to just stop trying the milk ladder, is this a bad idea? Could it develop into an IgE allergy?
Yeah, I mean, I think that's so interestingly in Leeds, the babies, that with non-IgE milk allergy are managed in the community clinic. There comes a point at around sort of 18 months of age when the dietitians are struggling to get cow's milk into they would refer to our clinic. So we've got, hundreds of kids, age 2 and above who are non-IgE to milk. I mean, I think it is important to keep pursuing it, because I think otherwise, if you think about sort of the social and the sort of the health sort of distraction, having this child who can't eat school dinners, or, my impression is there's very few babies or children that don't have a tolerance level. So certainly, we build up, and we may get to the stage that, the babies can have, kids can have butter in food or kind of cooked cheese, but might not be able to tolerate yogurt or fresh milk to drink or ice cream. But as long as we can get to a stage that those kids can have normal school dinners, can go to kids' parties, can take their girlfriend out for dinner and don't have to worry too much about what they're eating, that's sometimes the end point. And I think it's interesting. I think if you go, and I see it now, if I take family histories now about food allergy, it's not uncommon for me to see a milk intolerant baby. And if you ask us any family history, often the family or the parents will confess, oh, dad isn't very great with milk, or mum isn't great with milk. And I'm sure when you ask their parents, these have been sort of adults that have had cow's milk protein that was probably missed 30, 40 years ago, but they have some level. But now they sort of turn out to be adults that have sort of a bit of IBS with milk. And, they do sort of have to modify how much milk they can have in their diet. I do use quite a lot of probiotics in kids. If I get an 18-month-old that was struggling to get on the milk ladder, I do stick them on probiotics, and then our dietitians just sort of chip away and slowly try and progress. So there isn't any huge health detriment. It's more sort of the social and sort of mental well-being. You're trying to get these kids sort of to a level that they will tolerate.
Yeah, and I just made a comment. Absolutely. So in Berry, our dietitians actually transitioned to over-the-counter alternatives at 12 months.
Yeah, some do. Yeah.
Just to clarify a point. So for how long must cow's milk be eliminated from the diet to make a diagnosis of CMPA?
So certainly for the bottle-fed babies where you take it out, it's not uncommon to hear about significant improvement in a number of days. These children are better, but it can take up to sort of a couple of weeks. The breastfed babies do take a little bit longer, just because it takes that little bit longer to wash out of the breast milk. So we would certainly say up to sort of a month, for these babies it can take to get better, but it does take a bit of time.
Brilliant. So Timothy actually wants some clarification with regards to which probiotics do you recommend?
So the one that I should have shares in now is I tend to use Biogaia Protectis baby drops. And certainly, over lockdown, I was getting the families to buy it straight from Amazon. I then got a number of complaints because the instructions were coming in Czechoslovakian or Russian, but they can buy them from the company direct. And I think it's about 12 quid a month. And often they only need it for sort of 3 or 4 months, and it's 5 drops that the babies can add it. Mums could add it to any sort of milk they're having, as long as it's not hot food. The other one that we tend to use is Optibac, which I don't use as much of, but it can be used. Again, it's milk free, so we can use it.
Brilliant. So I know we're coming towards the end of the meeting, and someone's actually asked us, has the meeting ended? So very, very quickly, first of all, have you noticed an increase in childhood allergy as a result of COVID? Do you think is there a link there potentially?
I'm not sure we've seen an increase. I think what did happen is that for 3 or 4 months, we weren't rejecting referrals, but we had this calm where there were no one was clearly being seen, so no one was being referred. So I do think now we're starting to see a bit of a tsunami of babies that were diagnosed probably last summer that no one's done much about. So there is a bit of a floodgate. And I think more worryingly, what I'm seeing now is I'm seeing sort of babies who are 10 months old who physically haven't been weighed since they were born. They've pitched up, they've had their vaccinations, they've had a bit of advice over the phone from the health visitor, and certainly during the deepest, darkest lockdown, I was often encouraging mothers to buy scales to weigh babies at home from Amazon. 15 quid, you can buy some. They're meant for dogs or cats, I think, but you can buy reasonable set of digital scales. So there'll be plenty of those on eBay in the next sort of year as people try and sell them. But yeah, so we are seeing a very different type of medicine, and hopefully now that things will start to get back to normal.
What I will say is this meeting is being recorded, and potentially any questions that we've not been able to answer today, we'll probably try and share that with those who've attended. You've also got Nicola's email address in the chat function if you want any further information, you've got any questions, you need to speak to the medical team. Nicola will be happy to support you. Take that email down, because obviously that also is the source of your certificate, and it saves me getting a lot of emails about the certificate. So, but unfortunately, I don't think Donald can hear me, but what I will say is, first of all, thank you to the attendees for joining. Thank you to Donald for his presentation. Keep safe, everyone. But very, very lastly, I think to summarize, check the diagnosis for definite, so to speak, consider other potential causes. As a practice-based pharmacist, I would suggest you maybe run audit searches, check that you're prescribing the appropriate and correct type of formula, and again, get involved with your community teams. I'm sure they can support you. Finally, nothing more to do except for to thank Nestle Health Science again for supporting us with this evening, and I've got no doubt we'll probably end up having to repeat this because there's a load of questions coming through, and we probably just need a bit more time next time with Donald, and hopefully a better connection. So folks, nothing more to say. If you can still hear me, good night, keep safe, and yeah, hopefully see you at the next one.